Toni Aiduk, and I also would like to thank Drs. Wright and McAlinden, Kathy, who's priceless, Dr. King and Dr. O'Malley for their input in the project, and special thanks to my mentor, Dr. Arna Alkon. She's an inspiration, encouragement, and I want to be like her when I grow up. The title of my research is Geriatric Competency, Training and Services, Surveying a Local Aging Access Point. By the year 2030, 61 million baby boomers will be between the ages of 66 and 84. Add to that cohort the 9 million oldest old, those born before 1946, and a significant number of 70 million individuals will need access to aging-related services. Let's look at what this means globally. This slide graphically illustrates changes in the global population, elder population, between the years 1950 and 2050. We see that the 65 and older population has steadily increased as the number of children under the age of 5 has, for the most part, declined. If these trends continue as expected, these populations will intersect about the year 2015. The United States is tracking with the rest of the world, and between 1900 and the year 2000, in 100 years' time, the older population increased 8.7%. This slide depicts the population increase for 60-year-olds in the Commonwealth of Massachusetts. We can see that between the years 2000 and 2010, the projected increase is 16%. And to bring it a little bit closer to home, we can also see the increase for the town of Bridgewater. Between 2000 and 2010, the elder population is expected to boom by 45%. In light of this, researchers and policymakers predict huge shortfalls in services and resources for the elderly, and document that even now there are too few social workers in the geriatric field, and many of the workers that are in the field lack professional geriatric training and may not be adequately prepared to help aging clients. These studies have focused on national estimates of need and availability of trained workers, and have for the most part not included information gleaned from a local aging services provider. This study addresses that gap using a community-based mixed methods approach. The study also attempted to gain insight into client needs that are the most challenging to resolve, and to find if there are existing gaps between resources and client needs. These are the 4 questions that this research broached. However, today we're only going to look quickly at number 1 and number 3. How do frontline workers of a typical regional aging access point assess their geriatric competency? And are there gaps between resources offered by the agency and client needs as perceived by the frontline and managerial employees? So what? Why should we be concerned, and what does all this have to do with us? Think for a moment. Have you now, or in the foreseeable future, a loved one, a parent, a grandparent, a friend who may be in need of supportive services that will help maximize their quality of life? Maybe they need assistance with rehabilitation therapy or personal care, meals, or chores. Where would you look for, or where would you suggest that they look for help? And when that helping organization is located, how important is it that the person who's assisting your relative or your friend is aware of issues specific to their age? How important is it they'll be able to offer age-appropriate delivery of services to older clients, to your special person? This research centers around one of those organizations, and as the title states, it surveys its services, its training, and employee competence in the field of aging. So nonprofit aging service access points, ASAPs, say that a few times fast, which are in every state, are provided for in the Older Americans Act. Massachusetts has 27 ASAPs serving elders in the Commonwealth, Old Colony Elder Services, the ASAP in Brockton, which serves Plymouth County, is the source of data obtained for this research. Old Colony is a large, complex organization which was incorporated in 1974. They have about 130 employees and operate more than 12 programs serving elders, their families, and caregivers. As stated in its flyers, the organization's mission is to provide services that support the dignity and independence of elders by helping them maximize their quality of life, live safely and in good health, and prevent unnecessary or premature institutionalization. On the screen is a depiction of the organizational layout of the 6 departments that were available for this study. The executive staff at Old Colony welcomed the research project and announced the agency's participation to the managerial staff. The director requested managers to participate through interviews and that they distribute the instruments to the frontline workers. 50 of the direct care workers at Old Colony responded to a quantitative 6-page, 2-part paper and pencil survey that was designed to determine their self-assessed skill level to work effectively with and on behalf of elders, to record their personal demographics, their educational background, and their professional experience. Workers were given 10 days to complete and return the instruments via self-addressed stamped envelopes. All instruments were anonymous, and 50 of a possible 64 were returned. The overall response rate was a sound 78%. The data was analyzed using a computer statistics program called SPSS. The qualitative part of this project consisted of 20 semi-structured interviews which were conducted with program directors, managers, and supervisors. Those interviews were recorded and transcribed. The questions were open-ended and included topics ranging from new hire backgrounds and training to challenging needs and, again, possible gaps between services and resources. You'll note that the survey respondents are represented by the pinkish colored blocks and the managerial staff are represented by the blue blocks. The quantitative and qualitative data came in quickly and was surprisingly more than anticipated, pleasantly so. So much so that it has been referred to as an embarrassment of riches. There was so much to look at and consider, but we have seen some results. 94% of frontline participants were women. Old Colony is rather diverse, with 60% of workers identifying as European American, over 15% as Cape Verdean, and almost 10% Haitian. The workers' age range is interestingly between 22 and 73 years old. I kind of got stuck on that one, but 46% of employees at Old Colony are actually 49 years or older, and almost 15% are 64 years or older. Answers to the question, how many trainings specific to aging have you participated in during the previous 3 years, resulted in a mean just below 8 trainings per employee. All but one employee found were positive about these trainings, and 87% indicated they would appreciate more aging-specific training opportunities. Because almost 15% of the employees are 64 or older, they may feel that they know what they need in order to serve other older people. In response to a later question, frontline workers would like training in over 90 aging-specific training topics. The Geriatric Social Work Competencies Scale is a relatively new instrument and is a list of skills divided in 4 main categories, each of which contain 10 skill statements. Each skill is meant to be rated on a scale of 0, not skilled at all, to 4, expert skill and able to train someone else. We're going to take a quick look at the specific skills on which the respondents rated themselves highest and lowest. The scores in the right column are the mean or the average score of all the cases. So we're looking at the first section, values, ethics, theoretical perspectives, and we can see that the high was applying ethical principles to decisions. I won't read the whole thing, but and the low was relating social work perspectives and related theories to practice. If we look at The second section, assessment, we'll see that we have a rating of over 3 for the first statement, using empathy and sensitive interviewing skills, and the low was 1 point below that at 242 for administering and interpreting standardized assessment and diagnostic tools. Excuse me. The third section, the high was also over 3. Number 1, establishing rapport, maintaining a working relationship, and the lowest was a 1.94 at utilizing group interventions with older adults and their families. The fourth section of the GSWC scale was interesting because the respondents tied on the strongest skill level, their rating for that area. So 1 and 9 both rated a high of 2.8, providing outreach and identifying available resources, and the low was developing program budgets, and you can read the rest. The 2 skills that the frontline workers seem to feel most confident about are in the assessment and intervention categories. They were both rated over 3, using empathy and sensitive interviewing skills, establishing rapport. We're just going to take a quick look at the mean score for each section of the competency scale, remembering that these are based on a scale of 0 to 4. So the first section, the workers rated themselves, their skill level, at 2.8, and the second was 2.9. For intervention, the score was 2.6, and for aging services, programs, and policies, they scored an average of 2.3. You can see the average score for all respondents and all skill areas was just about 2.7. Frontline workers and managerial staff were asked about perceived gaps between client service needs and available resources. Their many 130 plus responses were categorized into 9 groupings, and that's what you have before you. Some of the most frequently mentioned were gaps in the areas of transportation, for instance, to routine medical appointments or to chemotherapy or dialysis. There was one story related about a consumer who uses a wheelchair, and their appointment at the doctor lasted past 5 o'clock, and their transportation provider left them there because their day had ended, and they actually had to employ an ambulance to get them home that night. There are too few preventive services. Most services are after the fact. A woman may need help doing laundry when the washer is in the basement, but she's not eligible for that help until after she's fallen and is injured. Mental health issues was mentioned by everybody, just about everybody. There is a need for mental health professionals to make house calls. Issues about substance abuse, dementia, diseases, depression, and lots of references to hoarding. One worker related that she had gone to a consumer's house and noticed that there were just pathways through stuff to get from one place to another, so she immediately set up help to get the house in order and to just make it easier for the consumer. And upon returning 6 months later for a visit, the same worker was chagrined to find that the house was rapidly being refilled. So these are just a few of the numerous perceived gaps that were listed. One supervisor summed up the answer to the gaps question by saying the needs are so big, the resources don't meet them. During the interviews, many of the managers stated that care of the aging has increased in complexity during the past 10 years. There are so many more people with so many more requests for such varied kinds of assistance. The older population doesn't fit into a simple or even predictable category called old. They are diverse and complex, and it makes sense that their needs will also be diverse and complex. The list of gaps perceived by the frontline workers and managers attests to that. Earlier I mentioned that frontline workers suggested over 90 training topics specific to aging that they believe will help them to do their jobs better. Trainings that will enable them to serve the older consumers with whom they work. The workers' desire for training, coupled with the complexity and amount of needs, seems to indicate the importance of preparation and training to do work with elders. An important next step will be to examine, to explore how to equip those workers who are already in the field of aging to help them to grow in their ability and in their confidence in their skills, to help elders live safely and in good health.